I am going to demonstrate foot and ankle examination live. And with me, I have another two young dynamic foot and ankle surgeons, Dr. Neerav, who also works with me as foot and ankle surgeon. And we have Dr. Dhiman, who wants to carve his career into foot and ankle orthopedics, who is going to work with me as a subject. So whenever I talk about foot and ankle clinical examination, I say it's a rule of three. So three rules for the examiner. Examiner would do a standing and sitting foot and ankle examination per se. Examiner would do examination of footwear and examiner would do examination of gait. Three things for the patient. Please come in, Dhiman. If you could focus on Dhiman. So patient comes walking into the consulting room. Patient comes with the trousers folded up above the knee so that you are able to see the knee. And patient comes with the footwear on into the clinical examination room. And then you examine three parts. You examine ankle and hide foot. You examine midfoot. You examine forefoot. And you're doing look, feel, and move. So you're doing three things: inspection, palpation, and manipulation. And into this, you're doing again into palpation, you're doing three things. You're palpating for a topography, so topographical palpation, palpation of nerves, so neurological palpation, and vascular palpation. So essentially, it's a game of three for foot and ankle clinical examination. So let's start first with the foot and ankle clinical examination. So patient, as I said, enters walking into the consulting room and patient is sitting on a higher level couch. And as an examiner, you are sitting at a lower level so that you can keep the foot of the patient in your lap and you can evaluate, examine the foot and ankle of the patient. So this is the way whole setup of your consulting room goes like. So here in Dr. Dhiman is sitting and I am sitting here at a lower level and I'm going to take his foot into my lap for clinical evaluation. So what essentially you start with is examination of foot and ankle per se. So for the examination of foot and ankle per se, the first thing you do is you do inspection. And I have made a schedule to evaluate foot and ankle in such a manner that I start with the medial side, then I go to the plantar side, then I go to the lateral side, then to the dorsal side, and then to the posterior aspect. So for a left-sided foot and ankle evaluation, you are starting anti-clockwise. And for a right foot, you are starting clockwise so that you don't miss out onto anything. So you start with hind foot and ankle, go to the midfoot, go to the forefoot. So you don't miss out onto anything. And this is how clockwise for right side, anti-clockwise for the left side makes sense to us. So the inspection, again, you inspect all these sides the way I described. So in an inspection, you look at the size and shape of the foot. You look for any obvious deformity of the foot. You look for the swelling, bony prominences, scar, or some marks onto the foot and ankle. You look for the position of foot versus position of the ankle, position of the foot and ankle versus position of the knee, whether there is any in-toeing, out-toeing, whether there are any scars. Look for the varicosities and also look for any obvious deformation. When patient is standing, look for the arches also. So this is what you're going to look into inspection. And in the inspection, you're going to go from medial side to plantar side to lateral side to dorsal side and to the posterior side. So for this particular foot, I find that there are some varicosities on the dorsal and the lateral aspect of the foot. Otherwise, it seems normal. So inspection gives you some idea about where you want to focus your clinical evaluation. But the most important thing would be palpation. So for palpation, you start with topographic palpation, go to the neurological palpation, go to the vascular palpation. So let's start with the topographic palpation. And topographic palpation is a game of index finger, either index finger of the patient or index finger of the surgeon. Patient points out at the painful area, at the area which gives him problem, and surgeon essentially evaluates various area, palpates various area with the index finger or with the thumb. My clinical evaluation in form of topographic palpation always starts with palpating medial malleolus. Why so? Medial malleolus won't be tender in most of the conditions of foot and ankle. If medial malleolus tenderness is elicited, I need to keep in my mind that yes, this patient might be hyperreacting or malignant. So start my evaluation, topographic evaluation from medial malleolus. I have marked medial malleolus over Dr. Bhiman's foot, and from medial malleolus, I slide my finger anteriorly, and what I palpate anteriorly is from anterior reach to the posterior reach. I am going to palpate deltoid ligament. Going forward and upward from the deltoid ligament would be a medial gutter of the ankle. And it is here that when the patient has got osteochondral lesion of the talus, you do slight plantar flexion and palpate deeply. Patient could have pain if the OCD, osteochondral defect of the talus is there. From medial malleolus going down, the first bony prominence which you encounter is a navicular tuberosity, which gives insertion to tendon of tibialis posterior. So you palpate the navicular tuberosity. From the tuberosity, if you go upwards, what you palpate here is a tibialis posterior tendon, which would be diseased into the acquired flat foot cases. Going forward, you could go behind the back of medial malleolus, very adjacent to the posterior border of the tibia. Posterior medial border of the tibia would be tibialis posterior tendon. Just behind tibialis posterior tendon, if you put your finger, there would be a tendon of flexor digitorum longus. We know Tom, Dick, and nervous carry. This flexor digitorum longus on the medial side is followed further medially and further towards tendoachilles, and you find your neurovascular. You can palpate your neurovascular structures. You could also look for any presence of swelling or any tenderness over the neurovascular structure. And the last structure here would be a tendon of flexor hallucis longus. On a medial side, you also go and palpate the calcaneus. When you palpate the calcaneus from posterior aspect and you come to the anterior aspect, suddenly there is a give way. On a posterior aspect, posteromedial aspect of the calcaneus, when you palpate, this area feels bony. And when you come little anteriorly, suddenly the bony feel goes away. And what you encounter is a soft feel, and this is called as a soft spot of heel. This is a very, very important area to palpate because neurovasculars, more so the lateral plantar nerve's first branch, which we call Baxter's nerve or nerve to abductor digiti minimi, or the first branch of lateral plantar nerve, passes through this area underneath the deep fascia of abductor hallucis longus muscle, which is a thick muscle palpable over here on a medial border, medial plantar border of the foot. So neurovasculars, they enter into the foot underneath the abductor hallucis muscles deep fascia. And if this spot is tender, that means patient has got neuritic origin of plantar fasciitis. And these are the cases which would need something different than the routine plantar fasciitis case. Mind you, these patients sometimes do have what is called as Valix phenomena. When you palpate here or when you palpate here, if the compression in the tarsal tunnel is very grave, patient might have proximal radiation of the neuritic pain, and this is called as Valix phenomena, and that is suggestive of a severe tarsal tunnel compression. So a neuritic element of plantar fasciitis should be ruled out by palpating the soft spot of the heel. Going back medially, and when you go up over the calcaneus, where where the bony field ends is an area which would get swelled up, which would be tender in a case where you have Haglund's deformity. So in an Haglund's deformity, this area would have a bony bump, which would be a tender bump. So this essentially finishes the medial palpation of ankle. From medial palpation, you go to the plantar aspect. If you could go a little back, Nirav. From medial side, you go to the plantar aspect. On the plantar medial aspect, you have abductor hallucis muscle, which sometimes gets hypertrophied, and that could also give rise to pain in foot and ankle, which could mimic like a plantar heel pain. Right into the center is your plantar heel pad, and this is a kind of pad which gets degenerated over the ages. Sometimes in a fracture calcaneus cases, post-fracture calcaneus cases, plantar pad gets atrophied, and you would really find that instead of a good palpable fat thick cushion, it would be a very thin flat layer of the fat. The plantar fascia per se takes origin from the medial tuberosity of the calcaneus. And so, in a plantar fasciitis cases, you will have tenderness at the medial tubercle of the calcaneus from where the plantar fascia gets origin. So, this is a facial variety. If you find tenderness here, this is the facial variety of plantar fasciitis. If you find tenderness here, it is a neuritic variety of plantar heel pain. And mind you, you could have both. Heel spur would be somewhere over here, which hardly is the cause of plantar heel pain. Mostly it is the plantar fasciitis and nerve to abductor digiti minimi getting pressed. Going distal from this area, you will be able to palpate the plantar fascia. And if you want to palpate the plantar fascia, you do what is called as a jack test or hyperextension of the great toe with ankle into 90-degree position. This will create a windlass mechanism, and there is a tough structure, tough taut structure, which is palpable here, is a plantar fascia. And this plantar fascia might be tender in the cases where you have distal plantar fasciitis. On the lateral side of the plantar aspect, you have abductor digiti minimi muscle, which could be tender in cases where you have a neuritic kind of heel pain. Some patients, they come to us and they say, Doc, I have a lateral sided heel pain. They are the cases which have got a pressure onto the lateral plantar nerve, which supplies to the first branch of the lateral plantar nerve, Baxter's nerve or nerve to abductor digiti minimi, which supplies to the abductor digiti minimi. So many cases of plantar heel pain patients, they do come with the pain on the lateral aspect. It is because of the pressure over the first branch of lateral plantar nerve or pressure over the Baxter's nerve or nerve to abductor digiti minimi. So once you are done with the plantar sided palpation of ankle and midfoot, you move onto the lateral aspect of the patient, and then if you can come from this side, yeah, and then you start palpating the lateral sided structures of the foot. The lateral sided examination is very, very important. So many key structures, they come in action on the lateral side. And again, the first thing you palpate on a lateral side is lateral malleolus. So I have marked lateral malleolus. Once you palpate the lateral malleolus, from there, if you go anteriorly, you palpate some dimple or gap. This is the lateral gutter of the ankle. And this lateral gutter of the ankle could be tender in the cases where post ankle sprain patients develop some kind of adhesions or synovitis into this. Going up from the lateral gutter, if you move anteriorly, you're going to come to the level of the ankle joint. Now, palpating the ankle is very important because when you're doing ankle arthroscopy, your medial portal would be at the soft spot of the ankle, which is just medial to the tendon of tibialis anterior. And for a lateral portal, you are again going into the soft spot of the ankle over the ankle joint line, which is just lateral which is just lateral to the extensor digitorum longus tendon. Going forward and towards talus from lateral malleolus, this is the area where your anterior talofibular ligament comes like. So from here, anterior talofibular ligament goes and gets attached to the neck of the talus. So this area, if it is tender, is suggestive of some pathology of anterior talofibular ligament. Right directly down from the tip of the lateral malleolus is a ligament which is traversing right down, inserting into the calcaneus, and this is a calcaneofibular ligament. So this here, if you have a tenderness, this is calcaneofibular ligament. If you have a tenderness here, it is ATFL ligament tenderness. Most importantly, the cases who have got flat foot may have diffuse swelling into all this area because of a heel valgus giving rise to impingement of calcaneofibular ligament and peroneal tendons between the fibula and the calcaneus. So you would see a diffuse swelling at the anterolateral aspect of the ankle. In cases where you have subtalar joint synovitis and subtalar joint arthritis, you will have a swelling which would be like a horseshoe shaped swelling little below this area. So you should be able to differentiate. Look at my two fingers. This is a finger which, if this area, you will have swelling of flat foot, lateral impingement, or a talofibular ligament, ATFL ligament. Somewhere down here, you would have tenderness and swelling and synovitis because of the subtalar joint pathology. Going back from lateral malleolus, what you palpate in the groove is your peroneal tendon. This peroneal tendon, you have a peroneus longus and peroneus brevis. You know that longus is a long tendon which goes from here through the cuboid tunnel and gets inserted into the base of first metatarsal to plantar flexate. And longus is away from the bone, brevis is closer to the bone, and brevis gets inserted into the base of fifth metatarsal, and they have a function of eversion of the foot and ankle. So you can palpate peroneal tendons going back over the fibula. From fibula, if you go towards the calcaneus, you really palpate a bony tuberosity, and this bony bump is an area through which very close to this tendon of peroneus longus would go, and this peroneal tubercle, it is called as a peroneal tubercle, could get hypertrophied and give rise to problems of the peroneal tendon. You can palpate the flat wall of calcaneus below this tubercle. This wall would get blasted, would be tender in cases where you have malunion of calcaneus fracture. From going down and anteriorly, the first bony prominence which you would palpate is a base of fifth metatarsal to which a tendon of peroneus brevis gets inserted. And your Jones fracture, your tuberosity fracture, you will have swelling and tenderness here. So this, one more thing, going down and towards the fourth metatarsal, the space which is there is a sinus tarsi, which comprises of the blood vessels, and sometimes it might get hypertrophied into a condition called as sinus tarsi syndrome. So you can palpate the sinus tarsi there. Okay. Typically, if you look for the approach, your approach, sinus tarsi approach, which is meant for this sinus tarsi syndrome, which is meant for MIS fixation of the calcaneus fracture, which is meant for subtalar fusion, which is meant for fixation of lateral process of fracture of talus, goes from the tip of the fibula towards the base of fourth metatarsal. If you extend it little below, you would be able to palpate and you would be able to encounter a bony prominence that is anterior process of calcaneus, and just there, just distal to that would be a calcaneocuboid joint. So this essentially finishes topographic palpation of the lateral side of the foot. And now we are to go posteriorly. Can you just turn around, please? Okay, thank you. Thank you, Dhiman. So posteriorly, in the center, you have your tendon of tendoachilles, and this would get swelled up into conditions which are called as non-insertional or insertional tendon. If you have a swelling and tenderness which is above the level of insertion of tendoachilles, this is non-Achilles tendinosis, non-insertional Achilles tendinosis. And if you have tenderness and swelling in and around the insertion of the Achilles, this is insertional Achilles tendinosis. Now, it is very, very vital for an examiner to differentially diagnose posterior heel pathologies by clinical evaluation only. So, there are two bursae. One bursa is behind, between the skin and the insertion of tendoachilles. So, behind the calcaneus, posterior to the calcaneus, but between skin and calcaneus, and this bursa is called Achilles bursa. Very rarely this Achilles bursa also may get inflamed in conditions like seronegative arthropathy, and patient could have a bump kind of swelling over here, which is tender. So you can palpate Achilles bursa here. There is a bursa which is anterior to the tendoachilles and above the level of the calcaneus. So if you find fullness and tenderness which is anterior to the tendon, above the level of the bone, this essentially is retrocalcaneal bursitis. So when you have a case with a retrocalcaneal bursitis, you could treat this patient with painkillers, NSAIDs, anti-inflammatory. Not responding, you may inject, or you may go in with a medial or lateral approach for resistant cases and excise the bursa in total. Going down, as I mentioned earlier, you have a bony prominence here. If you have a tender bony prominence here, this is an area for Haglund's deformity. Clinician is obliged to differentiate clinically that what are the conditions he is dealing with in a case of posterior heel pain. Is that only insertional tendinosis? Is that some bony prominence at insertion which is called as insertional spur? Is that retrocalcaneal bursitis? Is that Haglund's deformity? And management differs whatever is the clinical situation. As I said, retrocalcaneal bursitis, you could treat conservatively, failing which you could excise with a medial or a lateral approach. Haglund's deformity and retrocalcaneal bursitis can be treated with minimally invasive surgery, arthroscopically, endoscopically, can also be treated with calcaneoplasty. But mind you, you must make sure that your disease is not into the tendon. Whenever disease is into the tendon, you have insertional tendinopathy, then you are obliged to go posteriorly and take a tendon into account. The diseased tendon has to be removed. Insertional spur would also be palpable here, and for insertional spur, again you would need a straight posterior approach, and you need to remove the insertional spur when reattach the tendon which gets detached. So this is what is the significance of posterior ankle examination. Thank you, Dhiman. Could you just turn back? So coming to the evaluation of the midfoot on a medial side, followed by plantar side, lateral side, and dorsal side. Oh, sorry, I forgot the anterior ankle evaluation. As I said here, you start with palpating one tendon, and this tendon is a tibialis anterior tendon, followed by extensor hallucis longus tendon, and then you have your neurovascular and extensor digitorum longus tendon in raw from medial to the lateral, and you can palpate it. Soft spot palpation of ankle is very, very important here. Going down anteriorly from the medial aspect of the talus, as you come down, you will be able to palpate a joint, and this joint is a talonavicular joint. And it will also be corresponding with your finger, which you slide from the medial side and bring it to the navicular level. This area is area of talus head getting articulating with navicular and forming talonavicular joint. So that's about the anterior ankle palpation. Coming to the medial palpation onto the midfoot. There hardly anything. You have your navicular tuberosity, and if you go forward from navicular tuberosity, you are coming to a medial cuneiform, where would be the insertion of tibialis anterior tendon. If you start palpating the metatarsal, the usual palpation for tarsometatarsal joint starts from distal and comes proximally. So you start palpating the first metatarsal, and when you come up, you find a gap, and you can move your metatarsal and you can palpate first tarsometatarsal joint. Following that is your first cuneiform. Same way, the finger starts palpating the second metatarsal. From second metatarsal, as you go proximally, and you can move the second metatarsal between your thumb and index finger of the opposite, and you will palpate a second TMT joint and second cuneiform. Similarly, third, fourth, and fifth can be palpated in a medial and anterior aspect. As I said, in the plantar aspect of the midfoot, is the only important structure you palpating is your plantar fascia. Coming to the lateral side, I did mention that in the midfoot you have a calcaneocuboid joint and anterior process of calcaneus with the base of fifth metatarsal and bases of third and fourth metatarsals, which comes on the lateral aspect of the midfoot. Then comes the most important evaluation of forefoot. In a medial topographic palpation of forefoot, you start palpating onto the head of the first metatarsal, which could get swelled up. There would be a bony prominence, and that would be the scenario in cases with bunion or hallux valgus. You can also palpate for coming anterior. You can also palpate for anterior osteophytes or tenderness over the metatarsophalangeal joint, which is the case in cases of hallux rigidus or osteoarthritis of the first MTP joint, where you will find pain, swelling, tenderness over with palpation of osteophytes at the first MTP joint. Even gout cases would have diffuse swelling, redness, edema into first metatarsal for in case of an acute gout. On the dorsal, on the dorsal aspect of the forefoot, you start palpating the MTP joint, starting from distal, coming to the proximal. Again, for a second metatarsophalangeal joint, start palpating from distal, go from the proximal phalanx to the MTP joint, palpate for any synovitis, any swelling, any tenderness, any formation of second metatarsal. You can go proximally and you can palpate for tenderness and swelling over the shaft of the second metatarsal for a march fracture or a stress fracture of the second metatarsal. In an inspection, you already have looked for the presence of any deformities of the toes, and look for the deformities of the toes or obvious swelling. That you have already done in inspection. But for a palpation, any deformity is there, you palpate for the stiffness of the deformity and palpate whether the deformity has got tenderness or some swelling or not there. Okay. And coming to the plantar aspect of the forefoot, this is a very, very important area to be palpated. The most important thing you palpate is for presence of any callus over the plantar aspect of the forefoot. And presence of callus and the location of the callus is going to give you idea about what pathology this patient is having. Suppose this patient has got a hallux valgus, then he would be pronating and he could have callosity over this aspect as well as callosity over the first metatarsal. The hallux valgus patient, because of the overload, might give callosity at the metatarsophalangeal joint on a plantar aspect of the second metatarsophalangeal joint. Callosity has to be palpated for looking at the base of the callosity, whether the callosity is falling at the head of the metatarsal or is distal to the head of the metatarsal. And this is a very, very important palpation. If the callosity is at the level of the head of the metatarsal, then this metatarsal is giving more pressure during the metatarsal rocker onto the plantar aspect of the foot, and thereby you need a procedure where you need to dorsiflex the metatarsal. So you want to offload the pressure of the metatarsal head from the plantar aspect in such cases. If the callus is distal to the metatarsal head, that means it's a case where metatarsal is little longer and pressure of that long metatarsal is creating a callus, and in such cases you need to do shortening osteotomy. And sometimes you have both, where you need to do shortening as well as dorsiflexion osteotomy of the metatarsal. Any ulcer, if you see, you can palpate ulcer, and diabetic patients do have ulcers together with the deformity in the foot. So I guess I have covered all the aspects of topographic palpation of the foot. The next palpation is a neurological palpation. One nerve which we need to look at and we need to palpate is a superficial peroneal nerve. And you do plantar flexion and inversion of the foot. At the same time, you do plantar flexion of the fourth toe, and a nerve could be seen and palpated in many of the soft, thin and lean individual. You could palpate. If you palpate this now, it is advisable to mark this now, because whenever you are taking approach, maybe entry approach, maybe anterolateral approach, maybe arthroscopic portal, you might endanger some injury to this nerve. So this is a nerve which is palpable and visible in many individuals. For the nerve supply of foot and ankle, if you see a deep peroneal nerve would supply into the web space of first metatarsal. The rest of the area is supplied by the superficial peroneal nerve. On a medial side, it is supplied by saphenous nerve. On a lateral side, it is supplied by a sural nerve. This lateral side, the supply is by the sural nerve. In a plantar aspect, dead medial aspect would be supplied by the saphenous nerve. The rest of the supply would be by the medial and lateral plantar nerve, and sural nerve would also supply to the lateral strip of the lateral aspect of the plantar foot. So you look for the sensations, pain sensation, touch sensations. Sometimes if the nerves are thickened, you can palpate. You also look for what is called as tenile sign. Can I have the hammer? Yeah. Yes, sometimes you can percuss the nerve and look for the pain and tingling and numbness, which you can do like this, or you can palpate with a hammer and look for the tenile sign. Following the palpation of the nerves, you have palpation of vessels, and we know that we palpate dorsal pedis into the first wave space between first and second. We palpate anteritibial artery between the extensor hallucis longus and extensor digitorum longus at the level of the ankle, and we palpate posterior artery between the entry border of the tendo Achilles and the posterior border of the medial malleolus. Halfway down, we palpate the posterior artery. Palpation of the posterior artery together with the posterior nerve and looking for the sensations of these nerves is important, because when we want to give a local anesthesia or a ankle and foot block, we block saphenous nerve at this level, we block posterior nerve right in between these two, we block deep peroneal nerve right at the level of the ankle, we block superficial peroneal nerve about 4.5 to 6 centimeter above the tip of the fibula at the entry border of the fibula, and we block the sural nerve between the lateral malleolus and the entry border of the tendo Achilles. So that's how we block spine. We look for the palpation of major vessels, but we do forget many times most important thing is the nail blade circulation, that we should always palpate and look for the nail blade circulation. More so when you are on operative table and you're deforming, you're doing the correction of the deformity, it would be advisable for you to check your nail blade circulation for this case. So after palpations comes manipulation. So you want to manipulate various joints, you want to manipulate arches of the foot, you want to manipulate and evaluate for the muscles of the foot. So let's start with evaluation of muscle function for the foot. For that, the most important would be evaluation of tibialis posterior. Isolated tibialis posterior evaluation is one of the most important evaluation you want to do for your cases of flat foot and for the cases of club foot where you want to do transfer of tibialis posterior. So ask patient to put the foot on the opposite thigh, and then there are two ways: either you plantarflex the foot and invert the foot and ask the patient to maintain this position against your resistance. Keep it like that. Keep it like that. Don't allow me to deform. And then you can palpate over the tibialis posterior. And this is how you could do palpation of tibialis posterior muscle. Alternatively, you could ask your patient to plantarflex the foot and invert the foot. Invert. And you can palpate the tibialis posterior tendon. So that's for the tibialis posterior. We all know how to evaluate for tendoachilles. We know that for the EHL. We know that for the EDL, extensor digitorum longus. We know that for tibialis anterior, where you want to ask patient that invert a dorsiflex foot and then palpate. If you can focus here and palpate a tight tibialis anterior tendon on a dorsiflexion and inversion. This is how you could do. You could test, and then you give resistance and ask patient not to allow you to do that, and then you can palpate tibialis anterior. Most important palpation of the muscle is for peroneus brevis and peroneus longus. So for a peroneus brevis, we know that peroneus brevis is a plantarflexor to first wave. So lock your foot into inversion and ask your patient to plantarflex your first ray, and keep your finger over the head of the plantar aspect of first metatarsal and thumb onto the peroneus longus at posterior aspect of the fibula, and you can palpate the tightness of the peroneus longus. For peroneus brevis, you ask patient to invert the foot and you give counter pressure and palpate just above the level of fifth metatarsal tuberosity, and this is the tight peroneus brevis, which is closer to the bone. Longus is a long muscle which goes and runs from cuboid tunnel onto the plantar aspect and goes right at the base of first metatarsal to plantar flexi. So this is about the palpation of the muscles or the evaluation of the muscle power function. But you want to do manipulation of joints, and manipulation of the joint, it starts from the ankle joint to the subtalar joint to the transverse tarsal joint, and then individual TMT and MTP joint. So for evaluating movements of the joint, you could ask patient to do active movements, but what you are interested is to evaluate the passive movements also. And mind you, God has given two limbs for comparison. So don't forget to compare the movements of one limb that with the movements of the opposite side. Okay. So typically when you want to test ankle movements, passive range of ankle movement, how you really do it is you hold the heel into palm of your hand. So I am holding the heel into palm of the hand, and if there is any inversion or eversion or the varus or valgus of the heel, I am correcting it, and the foot is resting onto volar aspect of my forearm. And what I am doing, that I am gently taking this foot into dorsiflexion and plantar flexion. All the time, foot is resting on the volar aspect of my forearm, and my hand is correcting inversion or reversion. Relax it, and I am checking dorsiflexion, and I am testing plantar flexion. This is how you test for passive movements of ankle. For the movement of the subtalar joint, it is very, very important that again you are holding heel in your hand, and patient's foot is resting over my forearm, and my index finger and thumb is just below the ankle joint over the talus, and I am taking the heel into inversion and eversion. At the same time, I am palpating at talus to make sure that there are no spurious movements are occurring at the subtalar joint. Now, if I want to palpate movements at transverse tarsal joint, talonavicular and calcaneocuboid joint, they do have jog of movement. Again, I'm going to hold talus with my thumb and index finger, stabilizing it, and then I'm going to hold the foot with my other hand, and I'm going to do in movements in form of abduction and adduction, which is happening at the transverse tarsal joint. For learning about the movement of TMT joint, which is really very less in amount, it's very jog of movement, you can say. But what you are doing is that you're palpating the metatarsal, going to the metatarsophalangeal joint, and then with one other hand, index finger and thumb, you are moving metatarsal upwards and downwards. And this is also called as piano key sign or piano key test. Like a piano key, you are moving the metatarsal and palpating for movements at TMT joint. Evaluation of the movement of the MTP joint requires that you hold that particular metatarsal proximally, and with the index finger and thumb, you hold the distal part to that particular joint, and then passively take the joint into range of movement, compare it with the opposite side, look for any pain, crepitus, or restriction of the movement. This is how you do the movements of MTP joint. Similarly, you could do that for the IP joint and so on. So that is about the manipulation. The important manipulation is about the arch of the foot. And if you want to manipulate the arch of the foot, what you do is you dorsiflex the great toe and the arch would appear. And this is called as a jack test. It could be done with foot over the flat surface. You could also do in a dorsiflexion position. You could do this jack test to really manipulate your arch of the foot. So we discussed about the inspection, palpation, manipulation, and all of this thing was discussed into the sitting position. Then you ask your patient to stand up. Please, could you stand? So let patient stand, and with patient in standing position, you start your evaluation from the front, from the side, from the medial side, and from the back. And again, look for the gross deformation, the position of the foot with respect to ankle, position of foot and ankle with respect to knee. Look for any heel valgus, look for any deformity of the forefoot or midfoot. Again, you are looking for the presence of hairs over the dorsum of the foot, which would be there in the cases of neuropathy. And you are also looking onto the medial aspect. Could you turn your foot medially? So ask your patient to turn the foot medially. And if you see incidentally, Dhiren has got flattened arch. So he has got a flat medial arch. And so this is what you evaluate in a standing evaluation. Standing evaluation forms very important part of examination, and this is the evaluation which most of us miss. And if we miss, then we miss arch abnormalities like pes cavus, pes planus, or some deformation onto standing. Could you please sit down? So after the evaluation of foot and ankle per se, you do evaluation of gait. So that's your second evaluation. So for the gait evaluation, what you do is you need to look at the length of the step. You need to evaluate the symmetry of the body. You need to evaluate the movements of your joints, movements of the ankle, that of the knee, that of the hip. You need to look at the length, stride of the gait. And then gait, as you know, has got three main part. You put in your heel strike, then flat foot and toe. So you need to evaluate your patient walking from the front, walking from the side, look at the shoulder, look at the pelvis, look at the foot, look at the ankle, and note whatever are the abnormalities. And we all know that there are many different types of gait. For foot and ankle surgeon, what is most important is antalgic gait. I'm going to demonstrate two important gaits. So antalgic gait is a gait where patient has got pain. You could focus it at my foot and ankle. So patient has got pain and patient doesn't want to continue to be in this stance place. So he is very quick onto stance place, and whenever he puts his foot and ankle down, he has pain, and so he'll be taking that foot very quickly and immediately. So stride of the gait would be, and his step would be smaller, and patient would stand less time into the stance space because he has got pain into that. The another important gait which we all are interested as a foot and ankle surgeons is a drop foot gait. In a drop foot gait, patient is not able to dorsiflex the foot and ankle because of the paralysis of the dorsiflexus. So patient has a high steppage. Patient walks with the high steppage gait in a drop foot kind of a gait. So he lifts his knee to clear the ground, and when he lifts the knee, his foot gets into plantar flexion, and again he's going to step it down and walk. You have Dandelenberg gait, you have ataxic gait, you have a lot of other gaits. So you need to look into patient for his gait evaluation. After the evaluation of the gait, the evaluation of footwear comes in. So you need to evaluate the footwear and orthotics of the patient. As I said, patient is asked to come with his own footwear, and look at this. Dr. Dimant has got a footwear which has got orthotics into it. He has a footwear with a medial arch support. So when patient comes with the footwear on, and when you evaluate the footwear, you look for the presence of any wear and tear of the footwear. You look at the shape of the footwear and compare it with the shape of the foot, and look where the maximum deformation is. In a foot which is pronating, you will have maximum deformation on a medial side. In a foot where you have some forefoot abnormality, you may have some wear and tear at the forefoot. Look for the heel counter, whether heel counter is strong enough to support the patient, whether the heel counter is torn, how much is the heel counter's tightness or stiffness is what you need to evaluate. You also remove the orthotics from the footwear and ask your patient to stand over the orthotics and make sure whether the orthotics are working or not. Sometimes orthotics may not be giving support at the level where support is required. So ask your patient to stand over the orthotics and evaluate and examine your patient from all around so that you can evaluate the efficacy of the orthotics. Orthotist would not say to the patient that, look, this orthotics are not working. It is a doctor who will have to evaluate. Yes, the time has come for us to change to another orthotics, or time has come for me to go in for a surgical reconstruction. For a footwear of a sportsman, for a footwear of a normal person who is going into the walking and running and exercises. There are two important footwear tests which we should be asking patient to do or we should be doing. So the first important footwear test is called a flexion test. So you hold the footwear with one hand and you try to flex the footwear from the front. And if you try to flex footwear from the front, normally footwear would flex at the junction of forefoot and midfoot. If this footwear is flexing at many sides with multiple creases, that means this footwear is too loose and sportsman can develop injuries because of this footwear. The another test for the footwear is called torsion test. So you hold the footwear from the back and you hold the footwear from the front and then you try to twist the footwear. If the footwear is twisting a lot, that means it's a loose footwear and there are chances that this patient might get injuries. Or some for an arthritic foot, you may want some of this kind of the footwear. For a sportsman, this kind of a footwear not be a good footwear to wear. So evaluation of the footwear and orthotics would complete the foot and ankle examination. But at the same time, the most important thing would be Maninder, if I am overstepping, Kumar, if I'm overstepping, if I beyond time, just stop me. I can stop at any time. And Rahul, want to ask any question, you can always ask me. Yes, Kumar.
Yes, sir. I'm saying it's a masterclass, sir. Please go on. But if there was a question long back, one Dr. Shrey Singh, who is our member, he asked a question. Sir, tender point for Haglund is below retrocranial bursa tender point. He was asking about the tender point in Haglund, which probably you have already answered, sir. But if you wish, you can answer again.
Yeah. So as I told you, that Haglund is a bony bump at the superior and posterior aspect of calcaneus. So if you palpate a bony bump which is tender, which is anterior and above the insertion of tendo Achilles, that is Haglund's deformity. Yes. So for a Haglund's deformity to be tender, you will have a tenderness and bony bump which is anterior to the tendon and above the level of calcaneus. So somewhere over here. So above the level of insertion and anterior to the tendon, a bony tenderness or bony bump is Haglund's deformity. So right, you should be able to differentiate. Okay, there are certain special clinical tests which you need to do in foot and ankle. And let me start with this special clinical test for foot and ankle. The clinical test for tendo Achilles. There are three clinical tests for tendo Achilles. One clinical test is called Thompson's test, which we want to learn about the integrity of the tendo Achilles. Simon, can you lie down, please, on your back? Thank you. So, examiner either ask patient to sit on a table with Nirav. Can you focus here? Yeah. Examiner will ask patient to sit with a knee lying 90 degrees over the table, or patient is asked to be in prone position and knee is flexed to 90 degrees with one hand. If you squeeze the calf, you have plantar flexion of the ankle, and this is called as Thompson test. If when you squeeze the calf, or if you compress the calf and ankle does not get plantar flex, that means the tendo Achilles is torn. So there is loss of connectivity, integrity of tendo Achilles. This is going to be diagnostic for tendo Achilles ruptures. Another test is to know, can you just know about the tightness of the tendo Achilles, which is very common in foot and ankle disorders. You could have tightness of tendo Achilles tendon, or you could have tightness of gastrocnemius. So tightness of gastrocnemius versus tendo Achilles, if you want to differentiate, it is through the Silverskoi test. So the first is the evaluation of dorsiflexion of the ankle. Keep it loose. Keep it loose. Relax. Keep it lax. Yeah. So first, you evaluate how much is the dorsiflexion. If dorsiflexion is restricted, you want to know whether this is coming from this tightness, this restriction of dorsiflexion is coming from gastrocnemius or from tendo Achilles. So if The restricted ankle motion increases on the flexion of the knee. That means it is driven by the gastrocnemius, and gastrocnemius tightness is there. When you test ankle dorsiflexion in extension as well as in flexion of the knee, there is no change and the restriction of the movement remains like that. That means it is tendo-Achilles tightness, and this is how you would be able to differentiate. The most important thing while you are doing this test is to hold your heel into your palm, and foot has to be resting over the volar aspect of the forearm. Make sure that you have corrected heel varus or valgus. In fact, it would be advisable to put the heel into little varus and then look for the tightness of the tendo-Achilles and look for this test with heel in your hand. So, in a case of flat foot, you would have a valgus of the heel, and this valgus of the heel, if you are not correcting, you will feel that okay, there is no tendo-Achilles tightness, but there would be tendo-Achilles tightness. So that is what you need to work on. Diman, please. So that's about a test for tendo-Achilles. You need to learn about the test to rule out flat foot or cavus. To diagnose flat foot, what you're doing is, could you just turn around? Yeah. The one important sign is called as too many toes sign. Too many toes sign. So looking from the back, wide. Looking from the back, if you find that instead of one or two toes, you are able to see many toes, that means this patient has got heel valgus, and that's why you are seeing many toes. And this is called too many toes sign. Okay, come. One more test which you do for the flat foot is single heel raise test. Now, for a single heel raise test, you come. For a single For a single heel raise test, go far. Ask your patient to stand against the wall with your hands like this, and then you need to demonstrate essentially what you want your patient to do. So you demonstrate what you want him to do. Typically, what we ask patient to hold the affected limb first, hold from the knee, and patient is asked to raise himself on the toes to go up and come down. We ask patient to repeat this for 5 to 6 times. Mind you, old aged patients may not be able to do this. Mind you, patient might initiate this with a jump. So you need to watch for this and start with the non-affected side, and then do it on the affected side and ask patient to raise on an affected side. Normally, when patient raises on a forefoot, the heel would go into varus. Look whether that is happening or not. Can you focus here? Yeah. Raise, please. Yeah. So heel automatically goes into varus when the patient raises on a forefoot. If that is happening or not has to be observed. And if you ask patient to do 5 or 6 such continuous repetition or a case with tibialis posterior insufficiency, patient will not be able to do. For cavus foot, you have a test called as Coleman block test, where about a 2.5 centimeter size block is kept on the floor, and patient is asked to put the lateral border of the foot over the block, and patient is asked to drop the medial border of the foot. Examiner sees patient from the back. The heel varus which was there, if it gets corrected, that means this heel varus was driven from behind. If it does not get corrected, that means this heel varus was driven by the forefoot. So if you could turn around and show the way this is to be done. So he's going to put his lateral border on the block and drop the first ray, and we are looking at correction of the heel varus, whether it happens or not. This is called Coleman block test. And there is a reverse Coleman block test for acquired flat foot diagnosis, where you are asking patient to put the medial border onto the block, and if that corrects the arch, that means patient has got a flat. Okay. So again, in a flat foot by reverse Coleman test, what you are looking at is correction of the heel valgus, whether it is happening or not in the flat. There are syndesmotic tests. For a syndesmotic test, what you're doing is a calf switch test. Syndesmosis is somewhere over here, and when you compress calf in between two palms of your hand at the middle third level of the leg, if there is pain at the level of syndesmosis, that is suggestive of syndesmotic injury. This is not highly sensitive and specific test, but the external rotation stress test is very, very important. For an external rotation stress test, you're holding leg with one hand and holding the heel with another hand, with your foot resting over the forearm of the examiner. You are externally rotating the foot and looking at presence of pain at the level of syndesmosis. Now, mind you, there is a catch in this test. For evaluation of syndesmotic ligament, you bring your ankle into full dorsiflexion or into dorsiflexion, and then you externally rotate ankle. This is what is going to test the syndesmotic ligament. But if you are keeping it into neutral position and you are externally rotating, then you are testing the integrity of the deltoid ligament. So these two are the syndesmotic ligament test. Tarsal tunnel stretch test is one of the important tests which we do to really rule out the tarsal tunnel. Like carpal tunnel, like we have a brachial stress test for the carpal tunnel, we have a tarsal tunnel stretch test. So what you are doing in this test is that you are fully dorsiflexing the ankle, you are fully dorsiflexing the toes, and you are also everting the ankle and with the knee in extension. So all the joints are stretched, giving total stretch to the tarsal tunnel. And if there is pain and paresthesia at the level of the tarsal tunnel, this is suggestive of a tarsal tunnel stretch test. There is a cross leg test, which is also another important test with the highest sensitivity and specificity for syndesmotic injury, where you ask patient to rest his leg onto the opposite knee and let this fall down and let this go into external rotation. If there is a syndesmotic injury, patient would have pain at the level of syndesmosis. The instability test for the anterior talofibular ligament is an anterior drawer test. So anterior drawer test is done with patient sitting, relaxed, with knee flex and ankle lying into 15° of plantar flexion, and you are holding the leg with one hand, keeping your thumb at the level of ankle joint, and you are pulling the heel to the front, foot and heel to the front, and you're pushing tibia to the back. So this is the way you test for the anterior drawer test, which would suggest instability or the injury of the anterior talofibular ligament. And similarly, for a calcaneofibular ligament, you do a inversion stress test, hold the heel into one hand, let the foot rest over the forearm of the hand, and then you give inversion stress and test how much talus is moving. Again, all the time your thumb is over the talus to just locate whether talus is moving or something else is moving, and compare it with the opposite side. So that is about the ATFL and calcaneofibular ligament. There is a latchment test to know the instability of metatarsophalangeal or the toe joint. So to evaluate for a latchment test, you are going to hold the metatarsal proximal to the joint, and with the other hand, you are you are holding the distal part, and then you are trying to roll whole of the proximal phalanx over the metatarsal head and looking for the presence of instability or any click. So that is the Latchman's test for instability of MTP joint. Similarly, you could also evaluate the instability of other lesser toe joints. There is evaluation of first TMT joint in form of whether it is hypermobile or not, and this evaluation is important for management of hallux valgus. And for that, what you do is you hold the all other metatarsals with one hand and the first metatarsal with the other hand, and then try to rock first metatarsal in vis-a-vis the other metatarsals and compare the mobility of first tarsometatarsal joint. And so typically this is how we're going to do it and assess the mobility of the first tarsometatarsal joint, whether it is hypermobile or not. Similarly, you could also also examine and evaluate the hypermobility of the other TMT joint. Mutlers click or Morton's neuroma testing is done where with both the hands you are compressing the metatarsal. At the same time, you're keeping your thumb at the second or third intermetatarsal space, and you want to see that in a compression of this metatarsals, whether there is a click audible, whether there is increase into the symptoms of the pain, tingling, numbness or not. Tinal sign, again, I did mention that you could take a hammer and you could percuss over the nerve and look for the presence of neuritic signs and symptoms into the area where nerve supplies. There is a test called stress fracture test. For a stress fracture test, you need to percuss onto the bone which you are thinking has developed a stress fracture. You can percuss it and elicit the tenderness, or you can take a tuning fork and put it over, take the tuning fork and put it over the bone which you feel has got a stress fracture. There is a stress fracture test for calcaneus, which is called as calcaneus compression test, where you are holding the calcaneus into your palm, and then you are compressing the calcaneus between two palms, and if it is tender, then you feel that, and then you diagnose that there is a possibility of stress fracture of the calcaneus. For the first metatarsal pharyngeal arthritis, there is a test which is called as a grind test, where you want to press, you're pressing the proximal and the distal aspect of the joint and try to move the joint. And this compresses both the articular surfaces together. And if it is tender, that means there is some problem in form of arthritis of this particular joint. Lastly, Maninder wanted me to come up with a specific evaluation for a specific disorder. So, suppose you want to evaluate for a deformity of the foot and ankle. The deformity has to be evaluated from proximal to distal. So evaluate knee, ankle foot, midfoot, and forefoot. The deformity has to be evaluated into three planes: a sagittal plane, a coronal plane. Deformity for ankle could be varus, valgus. For midfoot, it could be adduction, abduction. So, in a coronal plane, you evaluate the deformity and document it. In a sagittal plane, it could be flexion extension, it could be equinus, it could be dorsiflexion. And in an axial plane, there could be rotational deformity. Supination and pronation would be a combination of such planes. So, for ankle, for midfoot, for forefoot, all these three planes should be evaluated, and you should be evaluating the deformity. For the deformities of the toes, it is important that you make your patient stand and document your deformity, again joint-wise, going from proximal to distal. metatarsophalangeal joint, whether there is a crossover deformity, whether there is a dorsiflexion deformity, whether there is a plantarflexion deformity, document that. Then go to PIP joint, whether it is a flexion deformity of the PIP joint, whether it is a flexion deformity of the DIP joint, hammer toe, mallet toe. Look for the flexibility of the deformity, the rigidity of the deformity, and look for the tightness of the muscles. Look for the availability of the muscle power, and accordingly you can plan deformity. What I do in my clinical setup is I would always like to draw a foot and ankle of the patient and put my muscles on a dorsiflexus. I am going to draw here. I'm going to put the power here, power of the inverter, reverters here, power of everters here, and then I plan my deformity correction, and based on muscle charting, I plan my tendon transfer. So deformity is essentially to be evaluated from top to bottom, in standing position, in sitting position, and into every plane with the rigidity of the deformity, with the available movement of the at the joints and available tendons and muscles for transfer. So that was for the toe deformities and deformities at the ankle and foot. I did mention about the evaluation of the callus. Where is the callus, and accordingly you would be able to differentially diagnose. I did mention, Maninder, about the evaluation of the flat foot. I did mention about the evaluation of cavus. So essentially, I feel that whatever I wanted to cover and speak about into clinical examination of foot and ankle, I have covered. We have Malhar and Rahul, who are also expert foot and ankle surgeons, and if I have left out something, they could really draw my attention to it. So Malhar, anything
No.
else?
I would like Rajiv you to demonstrate 2 or 3 things. One is how do we do for persistent dislocating peroneal tendons, the circumduction test.
No, that's a great point. On a lateral aspects, if you have injury to your peroneal tendon, the peroneal tendon could dislocate from the peroneal groove and they can come anteriorly. Now, this is the one issue which your MRI may not be able to diagnose. So you should be able to diagnose it clinically. And so for that, what you do is, for an active evaluation by the patient, you ask patient to do circumduction of the foot at the level of ankle and evaluate for any click or any snapping of the tendon when it comes out from the groove. And you could also passively take the whole foot and ankle in your hand and you could do this circumduction test. Normally, if you ask patient to do it, he'll be able to demonstrate, and you would be able to palpate that this tendon is slipping out of the groove and coming anterior. Rahul, anything?
Yes, sir. I think there is not much, rather there's nothing left. I would just like you to just reinstate the fact that while doing a Silver's cure test, how well we can negate the movement happening at talonavicular joint.
Yeah. So in a silver square test, whatever you want to do, you're doing at the level of ankle to see the tightness of tendoachilles. But mind you, talonavicular joint, if it is arthritic, could also give pain at the same time. And all arthritic joint in the foot and ankle might have associated tendoachilles tightness. So match your testing of the silver square test together with your clinical evaluation, where you will be able to notice that there is a palpable spur at the level of talonavicular joint, and you have tenderness at the level of talonavicular joint, which is associated with the tightness of tendons. 2 important impingement tests which I forgot and I just remembered. They are anterior impingement test and the posterior impingement test. The anterior impingement of the ankle, if you want to test, what you do is you again take the foot and ankle into your lap, put your finger or thumb at the lateral gutter of the ankle, and you dorsiflex the ankle and foot. And if there is a synovitis at the ankle joint following the injury, following the ATFL injury, patient would have pain, and patient would show the point of the pain and tenderness at the level of the lateral aspect of the ankle. The anterior impingement in a footballer's ankle could be because of the spur, which would be on the anterior aspect of the talus. Matching spur would be there at the anterior inferior aspect of the ankle, which you can palpate when you palpate in your anterior evaluation of dorsal evaluation of the ankle. For the posterior impingement, you have a presence of os trigonum at the posterior aspect, which could sometimes give pressure onto flexor hallucis longus tendon. And in those cases, you want to do a hyperplantar flexing test, where you are hyperplantar flexing the ankle and looking for tenderness and pain at the level of the posterior aspect of ankle. At the same time, you could also manipulate with the foot into hyperplantar flexion. You could also manipulate FHL, manipulate the great toe for looking at the pain while action of FHL is being done with the hyperplantar flexion of the ankle. Kumar, Mahendra, Maninder, anything else I have left out? Anything you want to ask?
Rajiv, I would just wanted to like to make a comment on the second MTP. You know, it's a very commonly missed pain, and it's a very good habit to do the subluxation test and the pressure test on the second MTP. Could you just demonstrate that?
So for the second MTP, when you want to do whether it is getting subluxated or not, as I demonstrated with the first MTP, you hold the second MTP, second metatarsal with one hand and hold the proximal phalanx with the other hand, and then try to rock the proximal phalanx upward over the head of the second metatarsal. The plantar plate injury cases would have pain and lot of subluxation, and there could be plantar plate tear in, and that would also lead to the deformity of the toe.
Thank you.
Sir, can I ask you something, sir?
Please.
Yes, sir. Apart from these local clinical examination, for the benefit of my audience, may I ask you, sir, where do you use injections of local anesthetic agents, local anesthetic injection in your OPD to aid your clinical examination, sir?
Yeah, that's a very, very important thing, injecting various joints to really determine which is the pain generator is very, very important. And more so in the cases after trauma. Post-traumatic malunion gives rise to pain at multiple sites. Say suppose a patient of calcaneus malunion. I do a lot of differential injectioning under image guidance. Now I started doing it under ultrasonography guidance, where the tendons or the nerves or the ligaments which are getting pressed or the joints which are painful, you inject in and around that joint, that tendon, that nerve, ligament, and if the pain subsides, that means that was a pain generator, and you need to address them, all this pain generator, while you are doing this surgery. So don't focus yourself to the arthritis of the subtalar joint for a malunion of the calcaneus. You may have a medial blast, and you could have a tarsal tunnel syndrome like problems. You could have a posterior impingement by the posteriorly located exostosis following a calcaneus fracture. For more so, you need injectioning technique for tarsometatarsal and midfoot arthritis. Sometimes on radiology, you feel that, oh, all the joints are bad. But clinically, there are very few joints which are symptomatic. So you may take your patient under image intensifier and you may differentially inject the joint and see. The problem with the small midfoot joint is that whatever you do, some injection material might spread into the other joint, and then you may get little confused. But yes, differential injections are very, very important for foot and ankle radius. They do help you a lot.
Thank you, sir. Thank you so much.
So I think that was a masterclass from Dr. Rajiv, which we just witnessed. And I'm really thankful for you, sir, to you, sir, basically. And I think we've all learned something, at least 5 to 7, 10 new points, which we didn't know before. So, and I've definitely learned a lot of things today. So I think majority of us have gained, and we are very thankful for doing this. And you've taken, you didn't stop for even a minute in between. So thank you, sir. And
Thank you.
Dr. Shah, Dr. Rahul, Dr. Malar, any other things which you want to say?
No, I think Dr. Rajiv has thoroughly completed the whole foot and ankle examination as he always
Malay,
does.
you're not audible. Could you be louder?
Sound is slightly low. Yeah.
I think he has completed the examination as he always does over the years, so there's nothing more to add.
Absolutely, sir. Just one point I would like to add, especially in case of neuromuscular foot disorders, that especially CP. So in that case, we would preferably like to expose the patient as high up to the pelvis, just to make sure there is no element of pelvic obliquity also. And I think that's the only thing we can just add to it. There's nothing else.
Important, because you're not Arjunas, where you just look at the foot and ankle. You should be looking at the spine. You should be looking at the hip. You should be looking at the knee. And you should be looking body as a whole, because there could be problem coming to foot and ankle from the higher level issues.
Right. So there's one question in the chat, sir. What are the deformities in hammer toe in the IP joints?
Okay, so hammer toe, you have a flexion deformity at the proximal interphalangeal joint. Mallet toe, you have a deformity, flexion deformity at distal interphalangeal joint. And then the claw toe, you have flexion deformity of the MTP joint, that of the PIP joint, and that of the DI.
Absolutely.
So in a hammer toe, which is long standing, you might have extension deformity at MTP joint. So to differentiate hammer from the claw toe you have flexion deformity of MTP joint with flexion deformity of PIP joint and flexion deformity of the DIP joint. For a hammer toe, you could have extension deformity at the MTP joint and flexion deformity at PIP joint. So that's how you differentiate all three. And crossover toe term was coined by Professor Michael Coughlin, where a toe deviates into medial or lateral side, and that is how it is called as a crossover toe.
Absolutely.
And there's a question from Dr. Hitin. He says that evaluation of medial ray instability is very subjective. He has found that evaluating the same with ankle in dorsiflexion and MTP also in dorsiflexion helps to better evaluate the instability of the.
Absolutely spot on. We must dorsiflex the ankle. Probably I missed on to that. We want to dorsiflex the ankle because we want to neutralize the pull of other muscle, and we want to specifically go to the medial ray instability. Again, it's a little controversial topic in foot and ankle. Many people believe into that. Many people do not believe into that. But yes, he is right. And if he dorsiflex the foot and ankle, it would be helpful. More specific.
So there's one more question which says that from Dr. Shrey, can we inject steroid in retrocalcaneal bursitis?
Yes, absolutely. Yes. You can inject steroid into retrocalcaneal bursitis, making sure that this particular patient has got retrocalcaneal bursitis only. And if I am to inject a retrocalcaneal bursitis, I inject patient into prone position and I palpate the area which is above the calcaneus and anterior to the tendon, and I inject. Mind you, before injecting, always aspirate and then inject. So that's what you can do for a retrocalcaneal bursitis. Majority of us do not inject for plantar fasciitis. But suppose you want to inject for the plantar fasciitis, your injection has to go dorsal to the fat pad, dorsal to the spur, and anterior to the calcaneus. So it is better if you want to inject, you take your patient under C-arm and start palpating from back over the calcaneus medial aspect, and then suddenly there is a give way. Now this give way tells you that you have entered into the anterior portion of the calcaneus. You need to inject dorsal to the fascia and above the spur, not into the spur. If you inject at the spur, the plantar fascia would rupture. If you inject above the spur and anterior to the calcaneus, that is the area you should be injecting. If you inject into the plantar region of the fascia, then you are going to endanger with plantar fat pad atrophy. So that is a specific technique for you to inject into for a plantar heel pain. It would be advisable to do it under C-arm, where you start palpating your needle, go from the back, come to the front, and suddenly needle goes in, and then you also see the spur, be dorsal to the spur, be anterior to the calcaneus. That is the place, if at all you want to inject steroids for plantar fasciitis, you should be injecting.
So I think that's right, sir. Basically, you want to say that you will be injecting between the bone and the plantar fascia. So in that space between the, but not exactly at the insertion, just a bit anterior to the insertion.
Not plantar to the spur or insertion.
Absolutely. There's just related question to that as well, sir. So some patients don't have tenderness at the insertion of the plantar fascia. Some have more tenderness, more distal to it, like in the mid substance. So what could be the cause, or what is your take on that?
So I said that there are two types of plantar fasciitis. It is a proximal plantar fasciitis and distal plantar fasciitis. So distal plantar fasciitis cases, and that is more common with the sportsmen, that is more common with weekend warriors, where they have a tenderness not at the origin, but tenderness which is distal to the origin of the plantar fascia. And this is called distal plantar fasciitis.
Yes, and I think we find these cases more in cases where we have inflammatory arthritis. They have more chances of getting a mid-substance plantar fasciitis.
And most important, when you have such a pain, you should also be palpating plantar fascia for any presence of nodularity or tender nodules, because that has to be differentiated with plantar fibromatosis.
Absolutely, sir. I think there's no other questions, sir, and I think we've covered the topic very, very well. Any other things? I think if there's nothing else, then I'll hand over to Dr. Shantanu to give the closing remarks for the session.
Thank you, Rajiv bhai. Thank you very much. It was a very comprehensive demonstration.
Thank you, sir. Thank you, our National Academic Director, my dear friend, Dr. Maninder. I take this opportunity to thank my two panelists, Dr. Rahul and Dr. Malhar Dave, sir, our president-elect, and also to our webmaster and the musician behind all our show, Dr. Indrajit. Not to mention my elder brother, Mahendra Bhai, my president, and last but not the least, certainly not the least, to my mentor, to my teacher, not only my teacher, teacher of everyone in IFAS, one and only Dr. Rajiv Shah, sir. I also thank my audience, which included colleagues from across the boundary, from Pakistan, from other country like Malaysia, Malaysia, from Singapore,
Bangladesh.
Bangladesh, also from South Africa. Dr. Paulo was there. So thank you very much for being there. Once again, I invite you all to our IFASCon 2021 to Kolkata, where Dr. Abhijit Bandyopadhyay is leaving no stone unturned to make it the greatest show of IFAS yet. So thank you so much. Thank you. Have a great day, a great time. Thank you.